The information presented is in no way to be considered as a standard of care, and the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The information is provided with no guarantee. All content is for informational purposes only and does not constitute the providing of medical, legal, or regulatory advice.
Good morning. Welcome to this episode of Blue Crew Medicine. Today we're going to talk about preeclampsia and eclampsia. So I've got some new people joining us today. There's Dr. Rachel Morris, who's one of our board-certified OBGYNs, maternal fetal medicine expert here at UMC. I get the pleasure of teaching stork with her all the time, so this is fun for us. And then the Davis Holiday is coming back, one of our flight nurses off Air Care 4. That was good. And then I'm Will Appleby, the Air Care educator and one of the CCPs. So let's get right into it. So we're talking about preeclampsia. So defining preeclampsia real quick, I stole this off Up to Date. Just so everybody gets the straight definition, it refers to new onset of hypertension and I can't ever say that. Proteinuria. Right. Yeah, that one. Or new onset of hypertension, significant end organ dysfunction with or without
severe features.
Yes.
I know the definition by heart.
Yeah. After 20 weeks.
Yes.
We see it all the time here in Mississippi. When y'all think of preeclampsia, what do you just think of right off the bat? Just straight up, no think. I mean, you get to deal with it every day. I think of high blood pressure, but
absolutely no. We have a huge problem with it in Mississippi, but it's a worldwide issue, and it unfortunately is still killing women and killing babies. So, for sure, I mean, rip-roaring hypertension and all the things. So they changed the definitions of preeclampsia a couple years ago, not to be confusing, but we used to call it mild preeclampsia and severe preeclampsia. So the definition is hypertension and protein, but it also includes features now, people that present with certain symptoms. So what we talk about now is you either have preeclampsia, so new onset hypertension with proteinuria, without the features or with the features. So the features are simple things: headaches, blurry vision, neurologic symptoms, right upper quadrant pain, elevated liver functions, twice the upper limit of normal, thrombocytopenia. Again, when you think of all of this stuff, you really have to think about it as a spectrum, but it has to be on your differential. And the crazy thing about women is 2/3 of preeclampsia happens postpartum. So it's not just the lady with the big belly. It's the lady who doesn't look pregnant, who doesn't tell you she just delivered 5 days ago, who comes in with hypertension. And again, if it was your blood pressure, no big deal. But my blood pressure, if I just delivered 4 days ago, a huge problem. Again, that can turn into even scarier things. So
that's something that comes to mind for me is what is our definition of hypertension, right? Like if we go pick up an ischemic stroke and somebody's got a 160 over 98 pressure, we're like, okay, fine.
That's tolerable,
right?
That's,
for
that's,
them,
that's
that's tolerable, but for these patients, that could turn into a problem.
Very quickly. So when it's every 3 in 50 pregnancies typically have high blood pressure.
Absolutely.
I think pretty much everybody at this table knows somebody personally that's had it or has definitely worked on a few patients, to say the least. Going down to eclampsia, just to go ahead and knock that out, the grand mal seizure that happens after. Eclampsia for me is like the bad day, right? Absolutely. So you got preeclampsia. I'm like, all right, my blood pressure's up a little bit, along with theirs probably. I'm concerned. I'm trying to prevent all these other things. Eclampsia happens. All right, now I'm really a little more worried about the patient and what I'm going to have to do and how far down the road are we going to go. So when you think of eclampsia, 90% of the seizures happen within a week
of the delivery. Yes, correct.
And it's important to say, like you said before, it's the mom after delivery. Those are the ones that it sneaks up on people, or like they don't ask. We get to do one of the simulations in the stork, not to give it away, but there's one that's like, hey, they're postpartum. Is that something is that a question you always ask?
Even on your mind, yes.
Yeah. You come in and look at you don't see a big belly, you don't see somebody, you don't see the baby with them. Obviously, they come to the ER. I mean, if it was my kid, I probably wouldn't come to an ER with a 2-day-old.
With a bad headache and a blood pressure 140 over 90. I mean, that's severe preeclampsia. What's interesting is when you talk about eclampsia, it's about 20% of patients who will seize have antecedent hypertension. Again, so it's not all of them, but the majority will have a headache. Again, so they'll catch you sort of off guard, and then, like you said, you have this seizure. And we don't really know why the seizures happen. We think it has to do with some kind of autoregulation dysfunction, cerebral hypoperfusion, ischemia, all the things, endothelial dysfunction, again, and then they seize real fast. But it can cause major other issues, stroke, intracranial hemorrhage. Again, there can be a lot of other sequelae. And of course, if this happens during pregnancy, that's a whole different can of worms that we're talking about, which is just as important. But you really have to be aware of what you're dealing with and recognizing. So you asked the question, what is hypertension? Well, 140 over 90 in someone who does not have hypertension is an abnormal blood pressure for a pregnant mother. In fact, severe range hypertension is not much higher. It's 160 over 110. In fact, that's a trigger to treat. That is the threshold to treat. And when you, again, talk about the conversion to eclampsia, there's a significant amount of mortality that occurs in that hypertension. So eclampsia we have to treat, and we'll talk about that in a couple minutes, I'm sure, but controlling hypertension will eliminate about 20% of your deaths in the setting of eclampsia. So it's all together. It's not just the eclampsia and it's not just the hypertension, but if you miss all of it and continue to prevent the recurrent seizures, which again, when you're dealing, we're smart folks out here talking about seizures and epilepsy and status epilepticus. This is not, it's very different animal.
Totally different ballgame.
Yeah, it really, really is. So, but again, it all fits together again, and the treatment is very specific. So if you've missed the fact that they just delivered, you know, it's a mess. So.
And let's talk about real quick, kind of bring it back a little bit about the pathophysiology behind a pregnant mother. So with, it's 40 weeks in an ideal world, 40 weeks, their body goes through so much changes, so many things, what's going on with them as far as cardiac output, their respiratory drive, what their oxygen demand is, everything you can think of as far as distal perfusion, their venous return, all those fun things that we deal with a lot in critical care medicine of like, what pressor am I going to use, or what drug, or what toy am I going to play with today. But when you think about a pregnant mother, or even postpartum, that change can't happen again overnight. They don't just go from, okay, they released a baby, now we're back to normal physiology.
Absolutely. It takes at least 6 weeks to return. Your cardiac output changes pretty fast after delivery, which is also a problem because that, 30% of cardiac output, in addition to the 30 to 50% increase that you've had over the course of the pregnancy, goes up even further to accomplish the delivery. And then you have this massive autotransfusion and drop of your cardiac output within the first 24 hours. But really all the SVR, all of that takes at least 6 weeks to go back to normal. Again, hypertension in pregnancy takes at least 6 weeks to go back to normal, or if it's preeclampsia or something else. So it's definitely not small potatoes. It takes a long time to fix these things. And sometimes they never go away. So unfortunately, when you have preeclampsia or other things, it increases your lifetime risk of cardiovascular disease and ongoing hypertension. So some people, I'm sure you've heard it, I had preeclampsia, well now I have hypertension, and I never got the chance to stop taking my blood pressure medicine because my blood pressure is always up now.
And it stays up. A lot of those patients, we live in Mississippi, so we have a lot of patients that are hypertensive at baseline. They live with some renal impairment or what have you, or just genetics of the way it is, or they're like me and they like to eat, so it's a thing, especially all the good food. But knowing what they were before they were pregnant, if they were already hypertensive, will they go up so much? Okay, great. But after pregnancy, urging people to go, whether you're the spouse or you're the pregnant mother, go do your follow-up. That's something for me. I almost sit on a soapbox for about 2 seconds and say, go to your follow-up. Don't blow it off, because you may miss something. Or you may realize, hey, look, you do need to be on nifedipine or whatever it is for the rest of your life, just to keep everything under control, because we don't want you to end up on dialysis or what have you. When we're talking about real quick about oxygen consumption, because it's real important to me, seeing it from the critical care perspective. We intubate people all the time. We deal with all kinds of weird processes like, cyanide toxicity, all these things about oxygen consumption and how much they really take. How much more oxygen does a pregnant mother, or even recently postpartum mother, take than a regular patient Joe Blow Schmo?
So with respect to just the pulmonary changes, you have to just, again, think about it. I have to keep it simple. Big abdomen increases your diaphragm by term about 4 centimeters. So again, physiology is simple when you think about it that way. Your total lung capacity, your tidal volumes, all those things decrease. Well, your functional residual capacity, decreases. Your total lung capacity decreases, but your volumes actually go up because the pregnant lady needs more. Again, the pregnant ladies, from oxygenation and ventilation standpoint, when they are pregnant, it's pretty miraculous how it happens, but the fetus has to exchange CO2 to the mother to be able to survive. And permissive hypercapnia in the mother is really not tolerated for that reason. So the mother, because of what is required to maintain a healthy status for the fetus, is actually a functional respiratory alkalotic. So she puts out more CO2 because the baby otherwise will maintain, again, it's just a shunt. So the mother, it's a diffusion of that CO2 from the baby as a byproduct, and the mother can tolerate it that way. But if the mother has normal CO2 levels, then that actually is a sign of impending respiratory failure. So again, it's really important, just to answer your question, again, their overall ability to maintain and to ventilate and their reserve is decreased. If everyone remembers that, then we're good. It's going to be a hard airway. All the things change. Progesterone dilates your airways, increases your secretions. Again, the pregnant airway, whether or not she looks like me or has a 500-pound, big, thick neck, it's going to be a harder airway. So again, having that preparation, assuming a full belly, all the preparations that you would normally take, but again, understanding that those changes, again, CO2 levels need to be lower. Again, your tidal volumes may be higher. Again, what they can do, and again, that they have such limited reserve. So I'm talking about a regular lady. Then you talk about a decompensated lady, or this heart failure lady you told me about. They have no reserve. So it's a much more of a decompensated picture when you talk about someone. And these are usually young and healthy people, right? Like, they don't have, for the most part, and so they look pretty okay until they're like about to fall off the cliff. So
I compare them a lot to pediatrics. We're all taught that they'll maintain until they don't, and they just drop off the cliff.
Absolutely, yeah.
Pregnant mothers are the same way to me.
Yeah.
They don't. They do fine. Usually the first trimester, they're pretty okay. Everything seems to be hunky-dory. You get in that late second trimester, third trimester, when they want to decompensate because of whatever insult or injury, whether it's trauma or metabolic or medical or what have you, when they fall off, they go fast.
Absolutely.
That's pretty much what you've seen too in our world. We go and Kelly's.
The one tidbit I'll add is kind of what Rachel was getting into is your ABGs you draw on these patients are going to be different. Mm-hmm. Their normals are different than my normals right now. And shameless plug, our MCS app has all these slides with, you can see their normals. So when you draw these ABGs and you see something a little different, just be aware that it's just not there. These pregnant mothers are not going to have the same ABG readout as
and
me
shouldn't.
and you.
Yeah,
right.
They shouldn't. If they do, you need to be more concerned, which is sometimes not really. It's hard to remember. Like, oh, that looks good. Wait a minute, that actually is not supposed to look like that, because good, normal is actually respiratory failure.
That PaCO2 of 45 is like, oh well, they're compensating. No, they're like
actually
in failure.
They're about to
you're about to have a really bad day.
Have to have a really bad day, and your baby's not tolerating it either. And when things are moving fast, we always talk about this in Stork 2. If you don't stabilize the mother, you have no baby, right? And eclampsia and preeclampsia are no different. If you don't stabilize the mother and treat her, well, then your baby's really an afterthought. So we have obligations to the mother, and all these obligations usually benefit the baby, but everything you're doing to stabilize her will give you a chance at having a good baby, any baby at that matter. So it's definitely one of the tricks of medicine, is recognizing that a pregnant woman and a recently delivered person is a totally different animal. And again, the respiratory system is like classic way of seeing how different they are, and just trying to remember that will save lives. So it's a big deal.
I'm glad you brought that up. It's one of the biggest points I wanted to bring home about this whole entire episode was treat mom.
Yeah.
It's real easy to get focused on the baby and, hey, what could happen if they're 28 weeks, they're already in distress, and you're worried about this, may have some congenital anomaly, and everybody's starting when you got the baby. You got to think about the mom at the same time. If you keep the mom calm, if you can treat the mom, if the mom is preeclamptic and the baby's in distress, well, treat the preeclampsia appropriately based off what's going on. And most of the time, the baby will do a whole lot better. Don't give the 2 milligrams of Dilaudid right before delivery kind of thing. But pet peeve of mine, when I see narcotics given like within an hour of delivery, it's like, okay, hang on for a second. You're going to make the baby distressed. Part of that's from my neonate flying all the time. But taking the 2 seconds to pay attention to mom, pay attention to what's going on, and say, all right, let's treat mom, and the baby should come out okay. So let's talk about identifying some of these preeclamptic patients specifically. Sometimes they have really subtle symptoms, sometimes they don't. The headache, the blurred vision. Again, there's all the lab tests in the world, but it boils down to the things we pretty much say on every episode. You have to assess your patient and talk to your patient. What's their history like? Has they changed in the last couple of days? Is there something that, hey, they've had a progressive onset of headache? Is it the thunderclap subarach kind of thing? What's going on? What tools? So for y'all, what tools do you use for an assessment as far as trying to figure out, hey, where do I need to go with this patient? Are they sick or not sick, or is this something I need to address right now, or are we going to watch for a minute and keep going down the road, or what tools do y'all use?
I think that verbal history is really important. I know, Will, you and I had a patient in the past that her symptoms that brought her into the ER was she had a headache and she was almost having an aura where she was having some tingling in her extremities, right? And the next thing you know, she's seizing. So that verbal assessment, what is different from her today? Like what's new in her pregnancy? Like, has she been having headaches? Is that normal for her? Does she have migraines? You compound that looking at her vital signs and how she's presenting to really formulate what's going on with her and getting a plan together.
I think a lot of patients, will tell me, hey, I just don't feel good. When a pregnant lady tells me she does not feel good, none of them feel good, right? So that's a silly thing to say, but when they when you can see them and you can tell that they don't feel good, it's almost like flu sometimes. Again, they'll complain that their stomach aches, again, whether it's right upper quadrant or their whole entire abdomen. They have these headaches, the blurry vision, seeing spots. It's not really a myalgias, fever, cough type situation, but you have to be careful because there are a lot of things that will overlap with preeclampsia, particularly cardiomyopathy. So you have to have that in the back of your mindset too, is this lady's function normal? But of course, the vital signs and just the overall presentation. I mean, I have the benefit of working at the hospital. I'm not in an ER. I have protein. In the clinics, of course, we're looking at all of that too in a dipstick, but it can be anything, a urine, a dip, a PC ratio. We use all those things to help us identify, and then all the labs. But the presentation and when did this happen? Is there anything else going on? Did you have this before? So a history of preeclampsia is your greatest risk factor for having it again. We use aspirin if we know that someone has had a prior history of preeclampsia. We give an 81 milligram aspirin. It's the only thing of all the studies we've done that has shown a significant reduction in recurrence of preeclampsia. But taking a history and figuring out that is something someone's ever dealt with will already clue you in, of course, to what could be leading your differential diagnosis. I mean, there's other things that we worry about, but that's certainly the majority of how they present.
So you get a patient that comes in your ER, I'll pick the fun numbers, 142/93.
Sure.
That's their blood pressure. They come in with a headache. She's got a little bit of a blurred vision. We'll kind of use the aura thing me and you had. And the patient comes in and says, I just don't feel good. Initial treatment assessment, all right, we're going to take a blood pressure cuff every 15 minutes. We're going to watch it, see if it comes down. If we're anxious because we're in the ER, we got the white coat syndrome, or we're dealing with the excitement of being in the ER, what have you. Oh, and she's 33 weeks pregnant. We'll just throw that number in there too. As far as your management, watching her escalate, you just watch her at first?
So if you have someone, again, technically it all boils back to the definition. So if you have someone with a 140/90 and a headache, and you have a dipstick that's positive for protein, and honestly the protein can even fall out of the definition. If you have the hypertension and the symptom, that's preeclampsia with severe features. So immediately that lady needs magnesium sulfate to protect her from developing eclampsia. And it, again, in a male or someone who's not pregnant, 140/92, who cares, right? It's just basic chronic hypertension. But for her, she's at so high risk of that evolution that you have to monitor it. Now, again, it's not a trigger to treat the hypertension yet, but you need to be cycling your pressures every 15. Need to send off the labs and make sure it's not HELLP syndrome, because again, that's a more severe variation of preeclampsia with severe features. But you can have hemolysis, you can have platelets that are in the toilet, you can have severe elevations of your liver functions. Again, that's indications for delivery, indications for mag sulfate. So you got to be looking at all of those things. But that lady then gets the serial blood pressures, gets moved to an obstetric unit, or gets transferred somewhere that can actually take care of her. Magnesium sulfate standard dosing. So we usually load somewhere between 4 and 6 grams IV over 15 to 20 minutes. That establishes a therapeutic level. Once you have that therapeutic level, she should not seize, and then you continue your MAG for usually 2 grams an hour. When you have someone on MAG, again, you have to know they're going to feel terrible. They get real hot and flushed and sweaty. They feel like they can't breathe. Well, then, okay, that's how preeclampsia feels too. We put Foley catheters in these ladies. You got to monitor their urine output. If they are urinating, you won't get MAG toxic. Again, if your assessments, again, in addition to blood pressure every 15 minutes, is a lung exam and reflexes, making sure that your MAG levels aren't getting too high. Again, it doesn't sound like a lot when you talk about a 140/90 with a headache. No big deal. It's a huge deal. That then requires such intense evaluation to make sure that you're not missing something. But again, getting that magnesium sulfate on board is how we prevent the eclampsia, which again, a lot of people forget because of the presentation being sort of mild, and then we have deaths.
Yep. A lot of people blow it off. I'll be
again,
honest.
Agreed. I get it. It's not a big presentation. You just have to know what's happening and not underestimate how serious it can be.
Definitely. The backside of that, you remember when we're talking about MAG, for those of you listening, it's one of those drugs. I really love it. I love all the properties you can use it for. You can use it for a lot of things now. It's coming back into fashion with cardiology and respiratory and all these other fun things. But keep in mind, you do want to watch their blood pressures, not only for making sure they're not progressing preeclampsia, but you don't want to make them hypotensive. If you do give it too fast, they will tank on you. That draw it up in a syringe and push it thing, let's not do that today.
Yeah, that's one of the things I wanted to bring home is that MAG is given for a lot of things, but it is not a benign drug. This is what this patient needs, but just like you're doing your serial blood pressure checks every 15 minutes, this isn't a hang it wide open and walk out of the room drug. I've seen it kill people, honestly. So please, when you hang this drug, make sure you got the right amount, the right rate. Go back in and check on them. Check your deep tendon reflexes. Look for those signs of MAG toxicity, because once you get into that,
you're in trouble.
You're in trouble. It can cause death. So please, it is not a benign drug.
No. Very, very much agree.
Give a real little shout out to my mother-in-law. Talking about she'll tell you all the time, they still to this day tape calcium chloride or calcium gluconate to the bag.
Yes.
She's an L&D nurse for 30 years, and just in case, it just wards off evil spirits. All they do it for, same thing like we do a lot of times, just put the epi by the head. But they'll do it just to ward off evil spirits. So just to remind them, hey, this is not a benign drug. We do have a way to kind of counteract it, but you can really harm somebody if you give it inappropriately.
We're spoiled on labor and delivery in that we get pre-mixed bags of magnesium sulfate, but to recognize that you have to put 20 grams in a liter or 500, you have to make sure that your calculations are correct. I've seen people roll in from an outside place running 6 grams an hour IV, and the patient's totally gorked out, about to code because someone didn't pay attention to what they should be giving. When you have someone who's preeclamptic, they're often oliguric. They're not urinating. So what I mentioned, again, 4 gram load, 6 gram load will get you therapeutic. sometimes you can't continue an infusion. If someone's not making any urine, the load is enough. The load's more than you need. If I have someone with end-stage renal disease, I don't load her with 4, I load with 2. And then I check a mag level every 4 hours to make sure that I'm not getting super therapeutic. Sometimes you just give boluses every 4 hours. It's an art to this medicine, and it is absolutely critical that it is treated just as serious as it should be, because again, we want a range of somewhere 4.8 to 8.4, but if you start stepping out above the 8.4, you lose your reflexes first, then it's a quick respiratory arrest and a cardiac arrest, again with a level of 15 or greater. Calcium gluconate, 1 amp, is how you reverse it and stabilize the membranes. But I mean, any pregnant lady on MAG should get a reflex at least every 2 hours. Again, you can check it every time you go in there. And if you don't have reflexes, turn the MAG off and administer the calcium, because again, it can get sideways so fast because of the physiology. Again, a pregnant lady should be urinating, her GFR goes up, she should chew through those drugs. But when you consider what changes in pregnancy, in preeclampsia specifically, it's all the reverse. Again, they're not urinating, they're not clearing their medicines, their renal function is poor. It's a pathognomonic for the disease, and so particularly this drug has to be monitored carefully. So.
Yeah. Now, all that scary talk aside,
yeah.
It is the drug that they need.
Yeah, so it came from, I brought the trial, so it came from the MAGPIE trial. So the MAGPIE trial is something that came out in the Lancet, I think in 2002. And the reason why you give magnesium sulfate over other things, again, y'all are trained differently than I am. Everybody uses, Ativan or Valium to stop a seizure, and that's fine. But when you talk about prevention of recurrent seizures, nothing else works but MAG. So you have a 60% reduction in seizures and a 45% reduction in maternal death. So this is a proven fact that nothing else works. And if you forget your MAG, you're going to seize again, and then you're going to end up with neuronal death and metabolic acidosis and respiratory failure and all these nasty things. But truly, the difference with eclampsia as opposed to epilepsy, for example, is a seizure in a pregnant lady is not that long. It's about 15 to 20 seconds at most. So for the most part, you don't even need all those other drugs. I mean, to be honest, like the seizure will stop, there'll be postictal, you're going to be worried about the baby, and the baby, has some changes. They don't like seizing. But once you start the MAG, you're stopping the future seizures, and for the most part, the seizure itself will handle it. It's not wrong to give the traditional drugs, but you really actually probably don't even have to. So
even us, and Davis and I are super fortunate. We have these wonderful NART boxes that are basically like attached to us at 24/7, 365 when we're on the airframe, and so like it takes nothing for us to draw up whatever. I mean, as far as narcotics, the time it takes watching a true seizure, 15, 20 seconds, we're not going to be able to draw up Ativan, Versed.
It'll stop.
It'll stop on its own
yeah.
usually before we can even draw it up.
Mm-hmm.
So keep that in mind. And if you're in an ER where you got to go to the Omnicell and sign your life away for a narcotic and then come back and get it, it's probably going to already be done. That's an easy way to tell, hey, is this a eclamptic seizure or is this a real seizure? Now, there are those patients that have a history of seizures and then they get pregnant and then they deal with this round robin thing. But for the most part, the eclamptic ones are quick.
And, we always say this, and I just got to keep it simple. If you have someone who does not have a history of a seizure and they're found down or have witnessed grand mal seizure, it is eclampsia until proven otherwise, because it's life-threatening. And if you don't do the things and, maintain their airway and get them in the treatments and the hypertension and all the stuff, you'll kill them or they'll die. Not necessarily because of anything anyone's done wrong, but it's just lack of recognition. So the ones with epilepsy, obviously, that's a different animal. Again, eclampsia is very rare, less than 20 weeks. Have I seen epilepsy with its onset presentation in pregnancy? Yes, I have. It's just one of those tricky things. You cannot assume that that's what the diagnosis is. And with someone with known epilepsy, obviously, just do all the things, get them to a hospital, and then let the high-risk physicians figure it out. So whether it's really just, because we don't deliver for epilepsy, but again, we do deliver
For
for
eclampsia.
eclampsia. Yes, yes, yes.
And as far as administration is concerned, you get into those patients sometimes that are just really hard sticks, and that's okay. You can give MAG IM. It's a different dose, 10 grams, divided into 2
Mhm.
5 gram, one in each side of leg or buttock. So an IV is not your end all be all. That's your administration. You can give this drug IM.
And it hurts, but it's absolutely, and what you're talking about, the 5 grams is considered the load. So you load somebody with 5 grams in each, and then you would still, if you can get the IV, then you would do the 2 after that. But again, you can continue to do the IMs, every 4 hours if you still didn't have an IV or an IO. The dosing, the IV dosing doesn't change through an IO, but yeah, that's a huge point. We do that on labor and delivery. People roll in and they have no access. We can't get anything. They're super clamped down, and we just give it IM. Done in the peds ER. It's anything.
Anything goes. It's about the patient. It's not about what's convenient for us. So
Absolutely.
Yeah, the shot may be painful, but death
It's
is
worth
more
it.
painful.
Yeah, exactly.
that's
Exactly.
it. The only advantage, I think, and part of the reason we still carry we have the 1 gram, 1 ml vials on the airframe. And that's the main reason for why we still have them. We could carry the premix we want, but we have the option of we can give it
Doing
IM or
that, or
IV or
both.
however we get presented with it that day. For those of you out there on an EMS truck or ALS truck and you have access to MAG, if you have 1 gram of MAG on your truck, it's not enough. Just get off that soapbox real fast. You need 5, so minimum. That'll get you at least 20 minutes. But make sure you have enough MAG. Make sure it's the appropriate dose, and make sure you have the right amount. Something I want to come back to real fast: the Foley thing.
Yes.
So a lot of people don't know that.
Yeah.
If you're making urine, you're okay.
Yeah.
If you quit making urine, you got a problem as far as MAG toxicity. So that employee, if you're doing an interfacility transfer or you're in a small ER and you're watching somebody and you give them MAG or what have you, go ahead and place the Foley.
Yep.
It's a quick, easy way to say, because sometimes these small outside hospitals, they can't get MAG levels. They can order all they want, but somebody's out to lunch or they can't get it back fast enough. They don't have the iStat version, whatever.
Mm-hmm.
And so Foley's a quick, easy way. Besides tendon reflexes, which sometimes people have trouble with, there's a lot of great YouTube videos out there. Shout out to see those. But just use your Foley as one way to double check it.
Yeah, I'll agree. Obviously, pregnancy, the GFR goes up, but the rates are the same. It's based on your weight. So if you have a normal urine output, then you should not get MAG toxic unless your rate's too high. So anyways, we love a Foley.
So when these people become MAG toxic, the gluconate dose, you give 1 gram, right?
Yeah, or 1 ampule, whatever you have.
So what is your preference over gluconate versus chloride?
I don't really have a preference. It's whatever I have.
Mm-hmm.
So the gluconate is what we carry on labor and delivery. So it's whatever you have. So again, I think it has to do with availability and stuff. At one point, I think we didn't have any gluconate in the hospital.
You can only get chloride, and so we were getting they're premixing something,
exactly,
pulling a third of it out, and
yes,
giving you this weird dose of things. But
right, yeah.
Yeah, we have access. Most everybody's got calcium chloride in their cart for sure. Sometimes people don't have gluconate. I know there's a couple of hospitals around Mississippi that they don't get it. It's expensive versus they're required to carry chloride, so they're just going to use that. Just remember, as far as chloride, good point you bring up. Chloride's 3 times the ionized calcium, so you may, if they're just a little bit, or you're trying to knock them back, you may give them a third of it instead of the entire amp of calcium chloride or entire syringe of it.
Gluconate has to go through that first pass liver effect, so just be mindful of that your chloride has 3 times the bioavailability of calcium immediately. So
we've gotten this patient, we've given them MAG. Okay, we're good, we're loaded. They're getting the MAG infusion. Let's talk about blood pressure control. Their blood pressure now is 157 over 100, or 167 over 100, and we got to figure out something to manage this blood pressure. They got the MAG. They shouldn't seize, but they're still hypertensive. Few drugs we play with a lot for us: labetalol, hydralazine, and PO, nifedipine. Is there a certain trigger pull on each of those drugs, or is there a certain rationale you personally like to use?
So The threshold's 160 over 110 to treat, and over 2 of those over 15 minutes. So it's not just one pressure and then she's normal range. Obviously, I wouldn't treat that, but if she's persistently severe hypertensive, that's my trigger to treat. You can look at the pulse pressure. Again, if you have a wide pulse pressure, then I do think things like labetalol will work. If you feel like you have a more narrow pulse pressure, they could be really vasoconstricted, and hydralazine might work. If you don't have IV access and they're not eclamptic and can maintain their airway, well then PO, immediate release Precardia is a great option. Sometimes, and again, it's understanding the physiology, people don't respond to one drug and then you give a couple doses. It's different than treating in the ER, again, a non-pregnant lady. These people can take such incredibly high doses of labetalol and hydralazine that you would never administer to an old lady. Again, 20, 40, 80. Again, we are pushing this stuff every 20 minutes, and they're just, ramming out severe range blood pressures with, just chewing it up. It's not even affecting them. So ACOG has a great algorithm. I don't have it totally memorized, although I've looked at it probably every day of my life for the last 15 years or since it's been created. But recognizing, again, you can switch from one to the other if one's not working. Again, the key is that you keep cycling your pressures every 15 and keep dosing every 20 until you get to 140 over 90. Let me say that again. Until you are not severe range. Again, it doesn't have to be less than 140 over 90, but until you're less than 160 over 110, you don't have to treat anymore. That's your goal.
I'd say until you get that trend going down instead of going up.
Exactly.
You want to, we want to maintain it, and then I want it coming back down to a little bit.
And sometimes in the hospital, again, we treat severe range hypertension with the IV, antihypertensives, but we will also sometimes add PO to those things. So labetalol 200 PO, Q8, again, to help stabilize, but not to confuse people, but severe hypertension has to be treated with an IV medication and treated until, again, it's not severe. But in our, we'll mix a little bit of the PO plus to help us stabilize, again, get sort of longer periods of not having those severes. But again, I don't have a true preference, but you can look at your pulse pressure and that'll help you sort of dictate which way to go, but use what you got. So keep it simple.
I think the point you brought up that was most surprising to me when I went through the Stork class was the dosages are so much higher. Much higher than I'm used to giving.
You think you're gonna just snow someone?
Like I can't tell you that I've ever drawn up 80 of labetalol and been like, this will be fine.
Oh,
I've done 60. I've never done
80. Gosh, that makes me nervous. But
we push it on a daily basis. I'm telling you, 20, 40, 40, 80. It is very easy to escalate. And you also have to be aware of your max dosing. So again, the Stork stuff on the app has the max doses. I believe labetalol is 220 milligrams total in a 24-hour period. So you can get there super fast in my world if you're mixing around with different things. And hydralazine has a 20 milligram max. So, in your world, if you're transferring somebody and they're still spiking these severes and you've gone through this algorithm and you've given all this stuff, you may have to use other things, cardine infusions, Cleviprex. We use other things in the critical care world just like you would to control the blood pressure. Because again, there is significant morbidity and mortality with this hypertension if it remains untreated. I like things done fast, but truly you have an hour from when you notice the hypertension, the severe range hypertension, to the recommended, it's again maximum of 30 to 60 minutes for treatment of recognition of that hypertension. So again, I'm like, come on, 5 minutes. It's passed. 5 minutes is passed. Where's my drug?
You'd like hanging out with us. We'll just drop it in
line. Just drop it in, get it in there. But you do have 30 minutes, again, is still a reasonable time frame to treat it. I would rather it treated faster than that, just my personal preference. But again, keeping cycling those pressures and watching it and getting that magnesium going is.
And I like the algorithm really takes the thought out of it.
Absolutely.
It's absolutely lined out where you start here. If this doesn't work, redose with this, and then you move on to this. It absolutely makes it where there's no thought involved. So if you have access to that algorithm, pull it up because there's no thought involved, and it lays out a direct pathway of how to treat these patients.
Mm-hmm.
Keep in mind, you sometimes get complex. We're talking about MAG with somebody that's in renal failure. They have a creatinine above 100, 1.5. And you're worried about, hey, are they going to get mag toxic real easy. Same with some of these drugs, depending on
Oh,
what
absolutely.
else is going on with them. If they've got a septic component, or if they've got baseline chronic renal failure, or what have you, some liver stuff. Just keep in mind, we're talking about giving these big doses, but it's all patient dependent. So if you got somebody that has this weird complex history, yeah, sure, shoot them with 10 or 20 labetalol, see what happens. Make sure you're reassessing your patient, taking, all right, how long is this going to hang around, though? Is this somebody that we would have to worry about, all right, the heart rate going to get too low too fast, or any of those kind of things, too?
You know, we've had a cardiac cripple. She was a cardiomyopathy. We didn't realize until, obviously, changes occurred. But her tachycardia was the only thing driving her output at that point. So the drug of choice, the initial hypertensive, she came in looking preeclamptic with severe features, and so labetalol was administered. You know, we took a nosedive on the tachycardia, and her output went to nothing. So again, you just have to be mindful of what's driving your bus. If it's cardiomyopathy or you're not sure, well then Hydral is probably your choice. That can cause some tachycardia for mama and baby, but again, for the most part, it's pretty well tolerated. We like to try to avoid labetalol in our asthmatics. Again, if you have severe range hypertension that's not responding to anything else, just recognize the side effects of labetalol. It can cause some, complications for asthma, but give the drug. If there's severe hypertension, you can't control it. You can control the asthma and you can control the airway if you had to, right?
Yeah.
So but we try to avoid it if we can. But again, that I will definitely never forget this case where, again, we slowed the heart rate and she really started to decompensate because
she didn't have that stroke volume compensation behind it.
No, absolutely not. So
something with labetalol and asthma, it can cause complications. For me, it's one of those, all right, cool, I got some albuterol here hanging out. We just give it to them, give them a little bit of help that way. The other thing,
and the mag can help with asthma too.
I was going to say, the mag, make sure that mag infusion's still
It's
going. Because that kind of helps to counteract it. So if you're getting both at once, you kind of already have that built. Just to throw in a little bit of other thing on top of that, BiPAP in these patients can be super comfortable for them and make them feel a whole lot better. I had 2 cases with that in the ER where they were, all right, they have asthma, pregnant. We're not eclamptic, thankfully. We're preeclamptic. But they were having asthma problems because it was Mississippi summer and there was everything everywhere and pollen all over the place. And it's like, all right, well, we can give them a little bit of mag, give them a little bit of other things, but BiPAP actually made them feel a whole lot better and they were able to sleep a lot better just because it took that positive pressure, give them a little bit of PEEP, and it allowed that diaphragm to actually push open a little bit better.
Yeah, interesting.
So let's talk a little bit about the eclamptic patient that you're worried about. Hey, we talked about these seizures last 15, 20 seconds, but what if it keeps on going through? They get persistent seizures. Does that mean we withhold on all the benzos that we're talked about, or the barbiturates, if that's what you're using, but typically the benzos or the Versed or Ativan? Is it bad to give those per se?
No, absolutely not. I mean, save the mother. So if you have a mother who's in status, again, that's a totally different animal. If you have a mother who seizes in front of you and you just feel better to give, it is okay, but recognize that in an eclamptic seizure, your baby's going to be bradycardic. Usually there's a transient bradycardia for about 10 to 15 minutes. If you're in the field or in an ER somewhere, you don't have obstetrics, again, you got to tolerate that, recognize it's happening, support with oxygen. Again, that'll help you break the seizure, get your mag going. They seize again, yeah, absolutely, use it. Again, and then also say, okay, is something wrong with my magnesium sulfate? Because if you have a therapeutic level, you shouldn't have ongoing eclampsia. You shouldn't have further seizures. So check your level, check your dosing, administer the meds. Again, stabilize the mother, because otherwise the baby's got no chance. So we know that these drugs cross the placenta. We know that they can cause sedation. Obviously, upon labor delivery, if we're doing something like this and we have to administer these medications and we're moving towards a quick delivery, because let's say the bradycardia doesn't resolve, well, then I'm talking to my neo team and letting everybody know, hey, I just gave this, your baby's going to come out super gorged, so that they're ready with whatever it is to administer to be able to help the baby. So, stabilize the mama first. Otherwise, you really don't have anything left.
What's, Dave, someone point this straight at you. What's your thoughts on Ramazicon?
Fine by me, I guess. I mean,
my only thing is a lot of people give it. You see those patients to go back into season or whatever after these. Typically, we're talking about you give them mag, you give a pregnant mom mag, and you say you give her 10 of Versed IM because you didn't have an IV and she's seasoned and you're worried about it, or that's the way it went. Do you think Ramazacon's a bad idea, or you think it'd be okay?
It goes back to what you got to do to help the mom at the end of the day. If you feel like it's something that can get you in a good place with mom because baby's going to respond to what she's doing. And then, like Rachel said, if you need to have your neo team ready, with whatever type of adjunct medicine that they have to get the baby, that's fine. But at the end of the day, like, mom is the priority. So if you feel like it's something that's going to help you, then yeah, sure.
But my only thought with it is it could sometimes it'll help you prevent intubating mom or having to go down a road of preventing aspiration or what have you. It can buy you some ways if you have access to Ramazacon. I've only worked for one ambulance service ever that had access to it.
Yeah, that's the thing is that's not something you're going to come across very often, but
it may keep you from having to intubate mom or put positive pressure or anything else that, like we talked about, has all those complications, which kind of leads me to my next road. So you have mom eclamptic, she's seized, or she's getting to the point where she's in respiratory failure from cardiomyopathy, or she's in heart failure, what have you. Let's talk real quick about the airway management, the intubation side of intubating somebody pregnant. And Rachel, you hit it perfect before. It's always going to be a hard airway.
Yeah.
Never play with it.
Glad I'm not.
It's
in charge of the airway.
Yeah, never play with it. It's a big belly.
Yeah. Full belly.
Are there things that you think of, Davis, that maybe you change your practice a little bit different?
Yeah, this is how many times have we been on here and we preach, set yourself up for success. You got to go into these people and say, this is going to be a difficult airway. Ramp your head of the bed up 30 degrees, okay? You're going to get that. And when you lay them flat, everything kind of compresses back on top of that airway. Get them up 30 degrees, just like an obese patient you would, right? If you feel more comfortable with the loaded bougie in your tube for these patients, do it. That's something that you need to practice. Have all your difficult airway maneuvers set up and ready because you need to go in thinking this airway is going to be tough. It's not your everyday little bitty patient, going to be an easy airway. And you may get in there and it's fine, but set yourself up for success. Don't get into a situation where you're like, oh my gosh, what do I do now? And have to start thinking down. Have that algorithm already out in your head, the steps that you need to take to have first pass success.
Something else a lot of people don't think about for me with airway anatomy, a lot of times our pregnant ladies, they swell or their facial features change. And so that can change how you bag them or how you put a mask on them. It can also change your internal anatomy too. So you get pressure pushing in ways that it may not normally, so that airway may not line up just perfect. The other thing is I always worry about the fat pad right behind the top of their neck. How are you do you put the towel roll under them or you hyperflex their neck? Can you get your partner, or somebody else you're working with, put your arm under there just to lift it up enough, trying to get the airway in line where you can see it better. Those, like you said, set yourself up for success, making sure you've got everybody you need or every tool you need to make it a little bit easier. Real quick, because it's a burning question. I know when we talk store to air care, I kind of gave Rachel a heads up like they're going to ask. RSI drugs.
Yes.
And mama.
Yes. So we talked a lot about how cardiomyopathy can look like preeclampsia, and you have to be careful. So particularly with intubation for a pregnant mother, rapid sequence intubation is always favored, and particularly, again, you can use whatever drugs you feel like you need to, but succinylcholine and etomidate are the two that are preferred in this situation, because if you use something like propofol and you have a patient who's a cardiac cripple, you probably drop your pressures in that situation. So, and that's from our OB anesthesia colleagues that recommend those drugs. That's what we're using up on labor and delivery. So that is sort of their favor. Again, always assume the full belly. Be ready for pulmonary edema. Again, particularly when you're talking about an eclamptic or preeclamptic with severe features. Again, you're going to have laryngeal edema. It's going to be hard. Their face will be swollen. I mean, it's a hallmark of preeclampsia is that their face and their hands are swollen. So everything on the inside is absolutely swollen too. Again, it's just, but those two drugs, I mean, that's the way to go. So straight from the OB anesthesiologist. Yeah, I'm not saying you can't use other drugs, but that is what they have favored. So
yeah, and we've gotten into What I've found in my practice is that people are way overdosing on rock.
Yeah.
Way overdosing. You can give half or 75% less of the dose of rock and achieve paralysis, but it doesn't have that long-lasting effect, right? How many times have we drawn up 100 of rock and then they're paralyzed for 45 minutes? I mean, that's just unnecessary. If you're just a huge rock fan, go with 50, even 25, and I promise you, it's gonna be they're gonna be paralyzed long enough, just fine. But sucks is the way to go. I mean, it's a shorter paralytic here, but if you're just a rock fan, don't use the full dose. You don't need the full dose to achieve paralysis.
And I'll say this, the rock, I'm a big fan of using lesser rock most of the time. Because they're high metabolic rate, usually and what's going on with mom, they're going to cook through it faster anyway.
Right.
Mm-hmm.
So, you give somebody, full 100 kilo person, 25, 30 milligrams of rock, that's usually enough to facilitate intubation, to get them sedated, to do what you need to do. You don't have to give them this big lugging dose, especially if you're worried about reassessment on mom and you don't want to hide something from you. That's what I like it better for, is you can reassess your patient a little bit faster than sometimes you couldn't otherwise. Same with sedation. So sedation meds, use whatever you need to use. Just be mindful of, if they are worried about delivery, when you get where you're going as far as transport, or if we're talking about imminent delivery, be mindful of what you're giving. If you're giving narcotics, specifically fentanyl or Dilaudid or morphine or any of those things, let whoever's going to be taking care of the baby know, because the baby's going to come out stunned or near apneic, and they're probably going to have to give some positive pressure ventilation or Narcan or something to get them through XYZ time period.
That immediate transition,
But don't worry about it. It's not the end of the world. Take care of mom first, and then we'll take care of the baby.
I'll tell you, COVID, over the last 2 years taught us a whole lot about sedation of the mother. I mean, I can't tell you how many times I walked into the unit and all the ICU folks were like, these pregnant ladies are chewing through my sedation. It's almost impossible to, and obviously it's in the setting of sepsis and ARDS and other things, so it's a totally different animal, but just, they are hard to control. It is, I mean, everything, it's why I love it, but it is much harder to keep them sedated and paralyzed. You can do it all. I mean, we do interventional procedures on our labor and delivery floor where we intentionally paralyze the fetus, and it wears off, and it's just fine to accommodate whatever procedure we have to do. So again, it crosses the placenta, it's fine. Stabilize the mother, treat the mother, maintain your airway and oxygenation. If you don't have a PaO2 of 70, you're not going to perfuse your uterus, and she's going to start contracting, and then you're going to get in trouble because she's going to start delivering. I mean, when I walk in the unit, they're like, oh, we're looking good, our PaO2's in the 50s, and I can see on the monitor she's contracting. I'm like, the uterus will tell you if she's happy or not. If she's contracting, you're not giving her enough. So it's a SAT of at least 95 and a PaO2 of about 70, a MAP of 65 or 70. Again, those are our happy zones. You gotta maintain those things. So
keep that CO2 around 30, and
exactly.
At least that PaO2 doesn't go below 80 for me, and then we're happy hunky dory.
Yes, exactly.
I think a lot when talking about sedation in the ICU. I remember a lot of our friends that work in the ICU and then giving the same complaint, and they were literally talking like, hey man, what kind of cocktail you got today, or this, that, and the other. And a lot of times what we do, or we get to do with some of the patients we deal with, we have to give them a cocktail, maybe Versed, fentanyl, ketamine, Valium, all kinds of different little things. We kind of play this little balance game of what works right for that patient, and then the constant stimulating environment of an airframe. The way I look at these patients with moms is, I was telling one of our pharmacy friends, I said, hey, so what you're describing is the same thing I deal with an 18-month-old RSV that I had to intubate, because they will literally chew through every drug you give them within 5 minutes. And you're giving them, normally an 18-month-old, we'll say we're giving 2 milligrams of Versed at a time, and you're wanting to give the entire syringe of 5, because that's the only way you're going to buy you some time to draw up the next one. Is that kind of what you've seen too, Davis, about as far as
these people like a cocktail. I'm a big fan of ketamine, and these people
Absolutely.
on top of your Versed fentanyl. I found that ketamine just gets them in addition to those others right where you need them to be. And you can give as much or as little as you need, obviously, but that's what we've put into our practice on anybody that's difficult to sedate. Our typical sedation med is Versed fentanyl, and if we're having a lot of trouble, we'll throw on that ketamine, and usually it'll get them where we need them to be.
I know propofol works pretty well a lot of times, but for me, I'm because of the risk of hypotension, I'm more worried about staying away from it personally in these patients.
And in our environment, and in an aircraft environment, propofol I've found it's really great when you're in an ICU and you can cut the lights off. And I've just found in a high stimuli environment, propofol, you have to give such high doses to achieve the sedation that you want that then you get into that hypotension, run. And I just don't like propofol in our environment, especially for this patient with the hypotension involved with the dose that you're going to have to give.
So real quick, since we're talking ICU stuff, we talked about a CO2 somewhere around 30 because they're going to borderline their respiratory alkalotic. That's how they maintain for the baby. PaO2 greater than 70, you really want at least 80. If you're dealing with these COVID ARDS or what have you, aspiration pneumonia, those patients that we've got to deal with in the last 3 years, we probably haven't got to deal with as much before. As far as ventilation management, because this is a question I've gotten phone calls at 3 a.m. about, to me, it's all same thing, low volume, high rate. Have y'all seen anything different? That seems to work better for the patients I've dealt with, and a little bit more pressure control or PRVC than volume. That's what they seem to like. Have y'all had any experience with that or any differences?
The stuff that the only thing I just want to say to keep in mind is this isn't the cookie cutter vent settings. It's just like, it's similar to a DKA patient where if you put that respiratory rate real low in a low volume, their CO2 is going to increase, and then you've hurt the patient. Just have that in mind that this isn't your turn on the vent and plug them in. You really got to have a little bit of extra thought behind it. I'm kind of like you. I like a high rate on these people. If you want more volume, sure, that's fine. But just make sure that you have an end tidal and you're monitoring your CO2 levels.
Correlate it. That end tidal CO2, let it be around 30, somewhere in there.
Exactly.
Another thing you can watch out for, we talked about cardiomyopathy a lot. Remember, your end tidal can correlate to your cardiac output. So if you have a sudden drop or a slow drop in end tidal CO2, you haven't changed their ventilatory status, or you're watching somebody spontaneously breathe, and they haven't changed their ventilatory status or how much they're driving, keep in mind that could be a sign of, hey, they're dropping their cardiac output. To the point about dropping the heart rate earlier, they can't compensate this, that, and the other. I'm by no means an expert in echoes or ultrasounds, or especially in the pregnant female. However, this is one of those times, if I've got somebody pregnant that I'm worried about their hemodynamic status, put a probe on them and look. Just see what that heart's doing. You brought up a great case before we started talking here about cardiomyopathy post-pregnancy, but that's a real thing. They're putting so much stress on their heart, and they're going through such a rapid change afterwards. It's something to definitely watch out for.
Yeah, and in that case specifically, we used our ultrasound as a trend. Like you said, I'm not an expert in cardiac ultrasounds. I'm not, but I can tell, what squeeze is better or worse. I can't give you a percentage of their, output or whatever, but you can use it as a trend. Specifically, we carry the ultrasounds, and we walked in the room, boom, that's our baseline. Titrated some drugs, boom, do we have a change? No, okay, here's what we need to try. That's just something to be mindful of, that you can use those tools as a trend, and we talk all the time on here about how important trending patients are, for sure.
I would just say, when you talk about ventilation, again, maybe I'm making it too simple, but mechanical ventilation should be almost the same, really, in a pregnant lady as a non-pregnant. And there's lots of variations and certainly specific cases and ways that you would adapt your volumes and stuff. Just, I think, recognizing the basic stuff, recognizing that your volumes will probably need to be higher for a pregnant lady, recognizing the airway's hard, again, and that CO2 level. I mean, that's the specific, changes for pregnancy. And there's more, but
a good thing to do on vent, going back to the vent settings, is just like on a DKA patient, what was this patient doing before?
Right.
Try to match exactly what they're doing. And, some people are better at that than others, but look and see, like, if she's taking in 30, 35 breaths a minute, try to set up your vent to match that. That's doing nothing but helping you, because that's her body's natural ability.
Response to.
Exactly.
Yeah, that acidosis. So.
Speaking of this patient that decompensates or gets worse, another question,
a lot of people ask is, all right, vasopressors, you got somebody that's hypotensive, whether it's pre-mag or they're a dehydrated pregnant patient that also happens to be, you know,
Third spacing everything. Yes,
Yeah.
it's super fun.
All-
yes,
all-
there's
all-
no
everywhere.
volume. Yes.
And it doesn't matter what you're doing and
Yes.
what drug you're giving. Nothing works well, but you got to bridge them. You got to take care of mom. Vasopressors, there's no limit. There's no, you know, give whichever you think is appropriate. For you, pretty much, Rachel, what's yours, Levo?
Yeah, Levophed first. We know that these things cause vasoconstriction, particularly at the uterine placental level. So we like a left lateral decubitus position. Obviously, fluids and crystalloid. If you feel like, depends on what their status is. Again, if it's preeclampsia, you know, you have a third spacing edematous patient who's, you know, volume contracted technically, but again, volume overloaded still. So we use crystalloids. Again, try and maintain a map of at least 70. Again, if you can't get there with crystalloids or blood, again, if you're talking about a hemorrhage, obviously, whatever it is, sepsis, it doesn't matter. If you can't get there with your basic 2, then you need to add pressors. Again, if you don't stabilize the mother, there's no chance for the baby. Again, we're talking about transient moves to get somewhere, to get to where, you know, an obstetrician or a high-risk specialist can intervene and figure out what to do next. So Levo first, always first, and then I don't really know what the right second is, and I guess it depends on your physiology and what you're dealing with, but certainly, and if you're hanging 2, we're in trouble. I mean, it's just, we're in trouble.
You're in a bad day already.
Yeah, this is the worst day now that you're hanging 2. But because really, I mean, the baby's probably an afterthought at that point. If you're on 2 pressors and you've done everything else and she's a trauma, you know, your baby's probably already to be gone. I mean, and if you're not close to an OR, there's really not anything you can do. Again, save the mother. She can have another baby later. So, but yeah, Levo first. Answer your question. Levo first. Same doses.
Same ballpark.
Doses.
I like the vaso as a second one.
I think
throwing
so.
my opinion in there, but we're also vaso nuts around here, so we can't say nothing.
Yeah, that's mine every day, every day of the week.
Epi's another one that usually gets brought up.
we used to.
Epi's a thing. Just be mindful of all the side effects of Epi and
Absolutely.
everywhere else it can go. But definitely, it's one of those. Take care of your mom. If you start going down the presser route, okay, yeah, cool. The 20-minute presser to buy you some time till you get blood or fluids or whatever you need to be on board, great. But if you're on a presser for a prolonged period of time, I read somewhere the mortality goes up through the roof. The fetal mortality is like 50% at that
It
point,
is,
but like
and
the mother goes up, I think 30%.
You know, every once in a while I'll walk into the ICU and, you know, the MAP's 95. I'm like, hey, we good. We don't need severe range blood pressures. You can turn the Levo off. Like, our goal is, you know, normal. And a pregnant lady, I will tell you, they will tolerate a lot until they just fall off. So when they start showing you signs of true decompensation, hypotension, pallor, you know, tachycardia, again, particularly we're talking about in hemorrhages or sepsis, they're so decompensated, you need to be very aware that they're about to die. So it's just, they're young and otherwise healthy, they can hang on until they've lost, you know, 2/3 of their blood volume, and then they have nothing left. So
then it's the bad day.
yeah.
Real quick, one last thing, HELP syndrome. Since
Yes.
we kind of touched it, and it's one of those things a lot of people don't get to, especially in our world, we don't get to see it very often. Most of the time, for some people, they never see it in their career. That's just something they have to take a test every couple of years, and HELP syndrome is always, it's an OB test, it's HELP syndrome. When you think of HELP, to me, I have a skewed definition, but when you think of HELP, is there something that you want to say is early recognition, and obviously is the first part of it, but as far as management or how you identify it and go, hey, this is going to be HELP, is there something that immediately comes to your head?
So I think a common misunderstanding is that you have to have severe range blood pressures to have HELP syndrome. People think, oh, she doesn't look that bad, it can't possibly be HELP. But the majority of patients will not have severe range blood pressures, and they will have this life-threatening disease. So it's often your 140/90s lady who doesn't have a headache, but her liver hurts. And this area, and that's again, right upper quadrant pain is one of the most classic presentations, and that's because they are maybe possibly having any Gleason's capsule, liver rupture, or bleeding. Again, I mean, this is what kills women, is when that kind of stuff happens. So I think, again, recognizing that you don't have to be the 180s over 120s kind of picture to have it. Unfortunately, the only treatment we have for it is delivery. So it's really about getting that mother stabilized, recognizing it, and getting her to somewhere as fast as possible so that someone who is trained to deal with it can intervene as quickly as you can. Because sometimes we'll try and manage to where we can optimize baby and give steroids for fetal lung maturation. But in certain cases of HELLP syndrome, again, there's a classification system. If you're really down a train, we can't wait. It's about getting the baby out of there, delivering the placenta to provide that stabilization. So hopefully they'll start to come around before they get too sick. So it is. And there are other masquerades of HELLP syndrome too, like fatty liver and TTP. You have to be very careful because it can look, hemolysis can look very different. You start talking about all these different things, and then you're really down a zebra train, but it can all look and present the same way. So I say, make sure you're checking your labs. Again, you have an idea of what it is, and then again, that magnesium sulfate saves lives. So
I think the biggest part, I'm glad you said it the way you did. They can have normal blood pressure.
Yeah.
Or relatively normal blood pressure.
Yeah, 140 over 90.
The first question I ask is somebody that I'm doing for preeclampsia or somebody that's pregnant. All right, what do their liver enzymes look like, and what's their platelet count? Mm-hmm. And it's one of those. Okay, cool. Not that it's totally off the plate of it can't happen, but it's less likely to happen if I ask it on the front end, or I have a bigger heads up, I should say. Davis, what's your
it's just. Help? And a lot of times when these patient comes in, there's a lot of excitement involved, right? You get caught up in what drugs you're going to give, this, that, and the other. My thing is just don't forget the labs, because that can tell you, that can paint a picture that is so different than what is sitting in front of you. Just do not forget to check your labs and then compound that with your assessment to see what direction you need to go in.
So I usually get a CBC, a CMP, or again, a basic profile plus the liver enzymes. I get a urine toxicology on everybody again, and coags, again, fibrinogen level. Again, if you're talking about elevated liver functions, which is part of the definition. So it's hemolysis, elevated liver enzymes, and low platelets. So with those three things, again, and a urine dipstick, of course, for protein, you can figure out a whole lot. Again, if your coags start going out, if your fibrinogen's downtrending, you're down a more serious pathway of other things. Again, it just tells you how is everything sort of working. And again, that's not just a one-time deal. We check it, and then we check them again. If something's abnormal, I'll check it in 12 hours or 6 hours if I'm concerned. If it's normal, usually it's a daily sort of check. But it can absolutely catch you off guard. And again, people think, I need to transfuse platelets if my platelet count's 50,000 or 60,000. Really, again, we follow regular hematology. We don't transfuse until it's less than 50,000. But that's really only if you're going to the operating room. It's not we're transfusing for a platelet count of 100,000.
They're not sitting on the floor with it.
Exactly. Yeah. No, we are actively managing these people, and the transfusion is not really what they need. They need to be delivered and managed accordingly. So it's, again, they'll just chew through your platelets if you give them, so it's sort of a waste. Again, if you're not, it's not a frontline management type thing. It's not anything anyone would do. And
you're not going to fix it. Trying to fix the number is not going to help anybody.
No,
it's not going to help.
It's recognition of the number. Yeah. Really, it's not trying to fix it. Yeah.
Well, great. This has been awesome. This is super exactly what I was thinking we would talk about today. Y'all have anything else you want to add about eclampsia, preeclampsia, or?
No, I just want to say to our listeners, if y'all have an opportunity to take the STORT class, it's amazing. You learn a lot. Also, our MCS app has all the slides and lectures and stuff on there. Once you take the STORT class and get access to that, it's a super good help. So if you have an opportunity, do not hesitate.
Yeah. The only thing I didn't say that I would say, people ask, how long do you use magnesium sulfate? Like, can you just give the load? Do you do the infusion? Do you stop it after 6 hours? So again, for people, I have the luxury of being on labor and delivery. So when you identify someone as preeclamptic, again, if you're moving towards delivery, then they get the magnesium sulfate continuously through the delivery and for a period of 24 hours after delivery. If you have someone, again, you're stabilizing, the magnesium sulfate is never turned off unless they're mag toxic or there's some other kind of issue where you feel like you have to turn it on. So start it and keep it going until you get where you're going. Again, if you're in an ER, again, start it, start the load, start the infusion, keep it going. It's not something you're going to turn off in a set period of time. This is, again, about identification, treatment, keeping it going, and then from an obstetric standpoint, just, again, to understand, like, how long is this drug needed for pregnancy or postpartum? It's usually a 24-hour treatment. Again, you can have people that come back, again, for eclampsia or something after they've already had preeclampsia. They've evolved into something else. Again, we re-administer the magnesium sulfate for, again, that 24-hour period is what is the standard of care. You might see some places where they will do 12 hours, and if the patient's really stable, they'll turn it off. That is not what is recommended. It's a full 24 hours of treatment after delivery. Again, and once you get the obstetrics folks involved, they'll help with that. But recognize, don't turn it off. Keep it going. Watch your urine output. Check your reflexes. Listen to some lungs. Sometimes people will have, with preeclampsia, they'll come in with pulmonary edema. And this is a little controversial, so I'll first of all say that. I don't know if what I do is right. But when you're talking about pulmonary edema and preeclampsia or eclampsia, it's Lasix, it's the 40s, head of the bed at 40 of Lasix, again, non-rebreather, 40 liters, whatever you have. So when you think about what's driving the bus, it's preeclampsia, okay? So the treatment for that to prevent them from seizing is magnesium sulfate, but that's volume. You have to give volume. So what we usually do is do all the things to dry up dry up the pulmonary edema, get that to go away, and then consider administering the minimum amount of fluids. Mag burns through an IV if you don't piggyback with something else. So you'll see our nurses do the minimum amount of volume that they can give to maintain the magnesium sulfate once you're over the pulmonary edema. But if you're not over it, you have to fluid restrict. Otherwise, you're not going to fit, like, you're trying to fix one problem and you're creating another. So that's the one area where I would say be very careful if you have someone who has preeclampsia with severe features, pulmonary edema, and eclampsia. Again, dry them up, fix that issue first, and then the magnesium sulfate can come after. Or perhaps that's where you use your 5 grams in the legs, and you don't give the huge volume or the continuous infusion. You have to get sort of specialized medicine, but again, it is not uncommon to do that. And if you continue to give a lot of volume, which the MAG requires, you make it worse. So that was the only thing I don't think we talked about. But this is super awesome. I hope people learned from today. And yeah, come take the Stork class. I mean, I think it's I'm sort of biased, but I think it's awesome, and certainly always available for questions. So.
Just bringing that up. It's okay to use IV nitro.
Yeah,
IV nitro, you can do low dose nitro and it'll drop your preload just enough to where, hey, you can prevent. It's one of those I'm maintaining, so it's not going to get any worse as long as I give them, we start at protocol, or a lot of protocols say start at 5 mics per minute and then you titrate up to effect. Well, 80 mics a minute, it's basically the same as what we do for MIs all the time, but you can start at 5 or 10 mics, and that may just help you maintain until that Lasix starts kicking in and that fluid starts going down, or what, a positive pressure, whatever you have to use, high flow, whatever may be going up the street. But that can buy you a little bit of time until you have to do something else. Again, you don't want to, like you mentioned, you don't want to get in this just snowball effect where it just go down the street.
Right.
So, guys, I appreciate your time. Thank you. This has been awesome.